We're going to talk about facial palsy, its differential diagnosis, the examination that is important to rule out the differential diagnosis, and the management in most important cases. If you want to classify the differential diagnosis, there are two major causes. One is the upper motor neuron disease, such as TIA and stroke, depending on the timing and the onset of symptoms. In upper motor neuron disease, we expect paralysis to be limited only the lower half part of the face. In other words, eyebrows and eye closure are intact. And we also expect to see other neurological deficit, which is mostly ipsilateral weakness. In lower motor neuron disease, the important causes is Bell's palsy, which is the idiopathic palsy of the seventh nerve. We have tumors such as parotid tumor. Also, middle ear infection and Ramsay-Hunt syndrome can cause facial palsy. In physical examination, we start by vital sign. Temperature is important because we want to rule out infection. Pulse rate because we want to rule out a possible atrial fibrillation which has caused the stroke. And blood pressure also because we are thinking about strokes. We should do a complete neurological examination that would include cranial nerve examination, upper motor neuron disease, lower motor neuron examination, and also cerebellar examination. Another important part is complete ENT examination with a special focus on ears. We want to check ears for the infection, for vesicular rash, which would indicate Ramsay-Hunt syndrome, and for lymphadenopathies. Depending on our positive finding in history taking and in physical examination, we will have some differential diagnosis. If we have suspicion of stroke, we should refer the patient immediately to the emergency department. If it is Bell's palsy, we would start prednisolone 1 mg per kg up to 75 mg for 5 days only. If our suspicion is about Ramsay-Hunt syndrome, we should add valaciclovir or famciclovir to the prednisolone. Eye protection is also important in both cases, and if we have any indication that the patient has any eye problem, we should refer the patient emergently for ophthalmologic assessment. If we have suspicions that the case is Bell's palsy, there's no need for any imaging and investigation. We should follow a patient at 2 weeks and 6 weeks. If there is no improvement by 6 weeks, we should refer the patient non-acutely for neurological assessment.